Thank you so much, Iona, for your highly respectable general practitioner point of view on pay for performance. It won't be easy for Jozé to beat her. But
I felt a little bit worrisome, and I thought it doesn't mind. There's a doctor in the room, so I will be okay, but I'm not sure now.
I'm sure you will do a good job. Success.
Okay. I'm not sure if I'm expert either, but I think I will have the point of view from a scientist, and I will show you just a little bit of my work and how I'm thinking and working at pay for performance, but perhaps more in general, transparency in primary health care. I think there was a lot of debate, as always, and there is also in other countries, about quality improvement. How should we go for it, quality improvement? And I think just as in many other countries, we decided to come up with guideline development. And to me, a natural step following from guideline development is making indicators, because we want to know if people are following these guidelines. Otherwise, there's no need in it. The guideline development in the Netherlands was supported by the Dutch College of General Practice. Was it by heart? I'm not sure. Imposed a little bit. And how about the indicators? Did they follow it by heart? Not at all. It was imposed to them, I think. But we worked together on several things. We worked on an accreditation program. We didn't work together on the pay for performance experiment, but now we have to work together on the transparency program. And I will give you some information about these different activities. As perhaps most of you know, the GP accreditation started out in 2005. It is a 3-year cycle. It's voluntary, it's on practice level, and what we measure is clinical care, practice management, and patient experience. What we measure was decided by the general practitioners themselves. They had to come up with smart improvement programs, and once you have done such an improvement program, then you get your own accreditation. And the accreditation is based on the judgment of an independent reviewer. The indicators in the system are about, no one wonders, I think, diabetes, COPD, asthma, and cardiovascular risk management, influenza vaccination, the uptake of survival screening, and some on medication. The general practices told us that it took them a lot of time. We all have electronic medical records, but then again, things weren't in the right places. They had to go through them then manually, so it took them a lot of time. We noticed that and said, okay, doesn't matter. Don't do all your population, just try out, give me some 40 people. And we saw that a lot of practices didn't come up with 40 people, but really were interested in the system and start to do them all. Anyway, it even helped them to improve administration. The other indicators about practice management were about infrastructure, team, information, quality and safety. We also had indicators about patient experience because we thought that was very important. The patient could tell me something about the general practitioner or about the organization, communication, access, privacy, and things like that. Was it effective, our accreditation system? That's a difficult question. I think you could say more or less that such an accreditation system has a kind of implicit effect. It is working on the improvement plans that was stimulated and that was accredited. And if you did your improvement plans well, then you got your accreditation, so it must have an effect. A quality mark was given and a list of accredited practicals became available. What did we do in our experiment on pay for performance? I must say, again, I tried to build up the program design bottom up. So I talked to general practitioners and to payers in our country, health insurance companies. We decided, since the accreditation program was already there, to get our performance measurements from the accreditation program. We had a little bit discussion about it, but it wasn't much. And they say, okay, let's give it a start. We talked a lot about how the measurements should be appraised and about the reimbursement. And we decided there should become a relative score for each domain. So for clinical care, practice management, and patient experience. And they also decided that clinical care was worth more than practice management of patient experience, twice as much. And we talked about what should we reward? Should we reward the quality level or the quality improvement? And we decided, well, it would be nice to have a model within that both things are rewarded. But then again, quality level should be rewarded 3 times as much as quality improvement. So it's not me who decided, it's the general practitioners who have decided themselves. And we talked about their yearly practice income. And we decided perhaps it should be something like 5 to 10% of the yearly income. Some striking aspects about this Pay for Performance project. It was also decided that the outcome indicators were not included. So the health insurance company were sitting at my table and they let it go. They say, okay, just as a start, it's not necessary. But what we want to know is the outcome indicator score themselves. So they weren't paid by them, but they got feedback about them. And they had a lot of discussions by telephone on all kinds of definitions of these indicators. And I liked it very much that also on the practice management indicators, we get a lot of telephone calls because people say, what to do next time? I already have been improving all my equipment stuff. So they started right away. What was the effect? I had a 10% raise on my clinical process indicators, and this patient and even the patient experience raised by 5%. Now I know as a scientist I have to be careful. I didn't have any controls. I don't know what the time Siri would have showed me, but I was quite impressed. These were voluntary practices, and they probably were into my project because they thought they could show off a very good thing, and even they could become better, or the administration must become better. Now look at the effect on the outcome indicators. As I said earlier, they weren't paid for it, but we saw in these practices that the outcome indicators on diabetes, HbA1c, blood pressure, and lipids, they all raised, even as the ones on the cardiovascular risk management, and it raised significantly. I was quite impressed. Where are we now? We have seen our project, we have seen our Pay for Performance, but actually it wasn't implemented in the Netherlands. A whole new a whole new project started, and it's called the Transparency. It was done because in 2006 we had a new Health Act in the Netherlands, and now we have to discuss together with patients, consumers, professionals, health insurance companies, inspectorates, and government. We are all sitting at one table, and what we are really doing is talking through all the indicators. And we are making indicators for general practice as well as for chronic care. But it is a little bit of a struggle, isn't it? There's a lot of discussion about the degree of the detail of the outcomes. And now, again, it has to be discussed if we should look at outcome indicators or on process indicators. And sitting at this table with all these stakeholders, do we really mean the same? When we are talking about the effectiveness of care, are we really speaking the same language? And there is a lot of problems around the logistics problems. It costs a lot of effort and a lot of expenses are involved as well. But I know it has a little bit effect on the quality improvement. So what should we do? Should we struggle on, perhaps saving money? That's where it stands, I should say, within the Dutch experience. Thank you.
Thank you so much. Oh, wait. Thank you so much, José. Please find your seat again, and Iona also. And then I try and get, we prepared some, well, might be better for you that I ask you to discuss with your neighbor for a minute or two what you think about pay for performance, where you are, where you stand, what you want, and what you think will be effective. So just hum. Pay for performance is destroying the person focus of general practice. Jozé, could you very shortly comment on it?
I think this is, do you hear me or not? Yeah. I think that's more or less the question, where is the patient in the P4 performance story? And I think, first of all, P4P, in my opinion, is part of establishing transparency on quality of care. And I guess that some people, just like me, are arguing that transparency is a patient-driven movement. Patients and payers both want information on outcomes of care. And it leads us to a lot of things. For instance, a data bank on adverse information and unprofessional behavior. And that restricts the ability of incompetent health professionals moving from state to state. It gives us programs providing information on quality of care. And it gives us also websites for patients to share experiences with all kinds of practices or health professionals. So what's the patient getting out of it? I think the patient is getting out for it information on quality of care. Now we can discuss if the information that is present nowadays really matters. But in that case, we are not questioning the content, we are just questioning the content and not the idea of transparency. So does the patient need all this information on quality of care? I think the patient does. Anyway, who are we to say that the patient doesn't? There are all kinds of new media and websites that gives us information on anything. For instance, if we all want to buy electronics, we look at websites, think what we can get out of it. Even in the Netherlands, we have a website. It's called Choose Better, and it gives us information on quality of care. Now, we can't question if it is a task for a doctor to come up with good information on quality of care, but I think it is by far means a task of a professional. So I would like to argue that transparency and quality of care, either when the indicators are or aren't part of a P4P program, is particularly helpful in getting the patient focus in general practice. Transparency in a healthcare system is regulating the patient's rights to become informed.
Okay, thank you. Do you need to pay for transparency? That's something...
Hey, yeah, that's my bit. Yeah, well, you seem to be arguing about pay for data. I think you can have all of that without the payment. But the payment motivation, especially when it's around thresholds, does terrible things to people. And I am reminded of the long retired general practitioner who wrote to me and said, "My 90-year-old husband has just been invited to the surgery for a cholesterol test. I want to ask you in whose interests you think this request has been made." The answer is obvious. The focus of that practice's attention was on meeting their pay-for-performance threshold. It was not on the individual needs of that particular family. And so I am absolutely not against transparency. I'm not against collecting data. I think payment for performance risks gaming and corrupting your data. I think that that's likely to be a really serious issue. I think it is paying for professionalism. We are professionals. We earn a salary. We shouldn't have a supplement for working to a high professional standard. I think we should accept that we're paid. Additional payments just corrupt us, corrupt the system, and certainly put money in front of the patient. Thank you.
Thank you, Iona. But it can speed up improvement. Okay.